Okay, we'll go ahead and get started. The goal for today is to finish up on different neonatal conditions. And I have a review sheet. We're going to summarize everything we've talked about. And next week, you guys will present on a condition. So you can use that cheat sheet that we're going to come up with later on today. Okay.
Professor, there's also an assignment for this PowerPoint that's due to maybe too long.
So you guys need a little more time.
Just to tap it.
Okay. All right, so I'll extend that due date and then the patient assessment due date has to be.
Thank you. Well, we will remind you.
Yeah, thank you, Mom.
You're welcome. All right, so we'll start off with transient tachypnea of the newborn. And it's nice when the name of the condition explains what's happening. Transient means it's there, but it goes away. Tachypnea, fast breathing. So the baby's born and is breathing fast. So we know what a normal respiratory rate is for a newborn, don't we?
40 to 60.
Very good. So 40 to 60 times a minute. If they're breathing 80 times a minute or anything more than 60 times a minute, we say they have tachypnea. And what can cause this to happen? So it's caused by delayed clearing of fetal lung fluid. And yes, Chris?
Is this a neonatal disease? It's part 1 or part 2?
Part 2. So we know that in utero, the lungs are filled with fluid. So the conducting airways have fluid in them. And during the birthing process, with a vaginal delivery, as the thorax is making its way down the birth canal, it kind of squeezes the thorax and squeezes out a lot of that fluid in the conducting airways. And then the rest of the fluid gets cleared by the lymphatics. Well, when babies are born via C-section, they don't get that squeezing of the chest during delivery. So they tend to have a lot more fluid left in their lungs after they're born. Sometimes it's not a problem, and sometimes we have to give extra oxygen, but it's not something bad that's happening to them. So it says delayed clearing of fetal lung fluid. It leads to tachypnea, and respiratory rate is 60. It can go up to 150 times per minute, but it's short-lived, less than 3 days. So it's just waiting for the lymphatic system to clear that extra fluid. It's most commonly seen shortly after delivery in full-term or late preterm babies. So you're not going to see it in your preemies. Mild hypoxemia may be present. So if there's a lot of fluid left in the lungs and the alveoli, it's going to interfere with oxygen getting into the blood. So that's what causes the hypoxemia. So the fluid gets in the way of oxygen getting into the blood. And then when you look at the chest x-ray, you see prominent perihilar streaking. This picture could be a little bit bigger, but you see white, so that tells you that you've got some infiltrates around the hilar area. So it's close to the mediastinum. So the perihilar streaking is the fluid that's still in the interstitial spaces and the lymphatics trying to get drained away.
Kind of a dumb question. I mean, it seems like a contradicting late preterm. What is that? What is that?
So they're premature, but not extremely premature.
Also later on, like closer to 38 weeks.
Mhm.
Okay, okay.
Yeah.
And why doesn't it happen with like premature, early premature babies.
Yeah, good
Feels like it would be
question.
The same thing, they still don't have the, compressions. So why wouldn't it happen to them?
That's a good question. I don't have an answer for that one.
Just curious.
So this is showing 11 hours later how there's improvement in the infiltrates. So eventually that fluid clears and then the baby's fine. It's associated with infants born by cesarean section because they lack the thoracic compression during vaginal delivery. Lung epithelium switches from lung fluid secretion to absorption. And that occurs with the help of circulating catecholamines and glucocorticoids. This may not occur correctly in some infants. So just the normal physiology is not occurring, and that'll lead to delayed clearing of the lung fluid. It's also associated with delayed cord clamping. So if the baby comes out, baby's still attached to the umbilical cord, still attached to the placenta. And if they hold on to the baby, but they don't clamp the umbilical cord right away, they're kind of waiting for a little more blood from the placenta to drain into the baby before they clamp the cord. So that's delayed cord clamping. When they do that, there's extra blood volume, which is a good thing because then they're not anemic. But one of the drawbacks is that with all that extra blood volume, it causes a difficulty in clearing of the fetal lung fluid from the lungs. So the excess blood volume causes a delay in clearing fluid from the lungs.
I helped deliver a baby the other day.
You did?
It was crazy. This woman came in with her sister, complaining her sister was she was having a seizure, but she walked in. And got her in the room and she didn't tell us that she was pregnant. So we didn't know what was going on with her. And the ultrasound went in there to try to get an ultrasound, found her on the floor. Then they came rushing out saying there's something coming out.
Oh,
So I went in there and there's something coming out. So
oh my word.
I had to help get her in the bed. We called the doctor, he comes in and, we started calling everybody to come help. And she delivered the baby in the amniotic sac.
Oh, no kidding.
Broke. So the baby was in there, you could see it inside. And he took my shears and opened the bag and delivered the baby. It was the craziest thing I've ever seen.
Oh my God.
How far along was about it was premature, it was probably like in 24 and 26 weeks or something like that.
Was it alive?
Yeah. Yeah, we suction, we bone suction and just stimulating the baby and we wrapped him up, put him in the warmer that was kind of on the fritz, but it was working for like 10-15 minutes going cold rescue to get him down to Broward General.
Oh my word.
It was crazy.
You never know what's going to come across in your day.
Yeah, we think that she might have taken some abortion medication and I think she suspected, but she didn't know how far along she was and initiated labor.
Did she have to be intubated?
No, the mom was awake the whole time.
Oh,
But afterwards, she started putting her clothes back on, like she was. It was the most surreal thing I've ever seen.
And where's this baby
I
gonna
hope
go?
they get social work.
Exactly, where's?
yeah.
I don't want that baby.
She already had 3.
Exactly.
She had
She's
three
putting her
kids
clothes
with her.
on, that's wild.
Yeah.
I was scared. Yeah, you never know.
Wow.
Get the baby oxygen,
Did you do an APGAR score?
I can't remember what the correct number was, but it was, I mean, it seemed to do okay. I mean, it started making noise and we wrapped him up in towels and really didn't tell. Like nobody really knew. It was so out of the blue. We just went into crisis mode and was like, hold on, like, you know, just shouting orders.
Oh, is that funny?
We had an old nurse that's been, she probably should be retired, but she's seen a lot, so she was there and she kind of helped orchestrate what to do next.
Oh, very good.
But we found out that the baby, once they got down to ground, it's still alive. Down ground Joe, it was like sucking its thumb and seemed perfectly fine.
Wow,
So, but
wow.
a lot of this stuff, I was like, I can't believe that this happened, and I'm right in the middle of going over this.
Yeah, I know that one.
Very cool.
President, can you repeat that last thing one more time? About the excess fluid. About the delay.
The extra volume causes difficulty in clearing the fetal lung fluid.
Thanks. So what are the symptoms? We're going to see fast respiratory rates. Because the fluid interferes with oxygenation, we're going to see some cyanosis. Grunting and nasal flaring are present. Just because they're trying to create some PEEP, physiologic PEEP. And when there's fluid in the interstitial space, it makes work of breathing more difficult and makes the lungs stiff, so lower lung compliance. And we'll see retractions occurring because of that. Okay, and then I think I have this. Now this is increased work of breathing, but this is definitely not a newborn. Look how developed the baby is. But you can see sternal retractions occurring. So how do we treat transient tachypnea of the newborn? Give them some oxygen if they need it. CPAP will help with opposing the fluid that's still in the alveoli. It'll help to keep the alveoli open. And mechanical ventilation is rarely needed. All right, questions. Neonatal tachypnea is defined as a respiratory rate of greater than A, B, C, or D. Letter C. A full-term infant is delivered via C-section and demonstrates mild symptoms of respiratory distress, including cyanosis, tachypnea, and nasal flaring. APGAR scores are good, and the chest X-ray shows hyperexpansion and perihilar streaking. Which situations most likely fits this case? Very good. So the infant has transient tachypnea of the newborn and will likely recover completely by 72 hours. So what were some of the clues in that scenario?
Very high.
Chest X-ray.
What about C-section? Yeah, C-section is a clue. And then the tachypnea and the chest X-ray showing the infiltrates. Very good. So there's a saying that C-section babies gurgle, babies born via vaginal delivery coo. So the gurgling is all that lung fluid coming up. So it's coming up like the first few hours of life and they're just because all that fluid is coming up out of their lungs. All right, next we talk about apnea of prematurity. This is cessation of breathing for more than 10 seconds. So more than 10 seconds is considered apnea. It occurs in infants born less than 32 weeks of gestation. So when babies are born prematurely, the brainstem isn't fully developed. And we know that the brainstem has the medulla that controls breathing. It's not fully developed. So they end up having periods of apnea. This just gives you a little more definition. It says premature infants are susceptible to apneic episodes because of immature afferent output from chemoreceptors, lung and airway receptors, and the central nervous system. So this is a baby that has a belt wrapped around its thorax, and it detects respirations. And if there's apnea, then it sets off an alarm. So if babies are having periods of apnea, they'll go home on this monitoring system.
Hey, Mom, could you add underdeveloped medulla oblongata to that list or?
Yeah, it says
central
immature central nervous system. So you come across the baby and they're having apnea, and we will stimulate them, and usually just stimulating them causes them to start breathing. It says if apnea persists, initiate ventilation with bag valve mask, use low FiO2s to maintain an adequate saturation. So if we have an apnea and oxygen saturation drops during that period of apnea, it's called A's and B's, apnea with bradycardia. So if the heart rate drops along with it, and then the O2 saturation drops, A, B's, and D's, apnea, bradycardia, and desaturation. So to treat apnea of prematurity, caffeine citrate is given. So you'll see the babies on, 1 cup of coffee every morning with their feeding. No, I'm just kidding. They give it as a medication. The other thing that helps is CPAP. So having air blowing into the nasopharynx acts like a stimulation. And if babies are placed on CPAP, they have less episodes of apnea and desaturation. So that's the connection. So why does nasal CPAP help with periods of apnea? So air blowing into the nasopharynx is a stimulant. Because it says here CPAP is given to reduce work of breathing, but just because they're having apnea doesn't mean that they have an increased work of breathing. So it's true that CPAP helps work of breathing, but CPAP given for apnea of prematurity is just because of the stimulation of the air blown into the nasopharynx. It'll reduce the number of apnea occurrences. So that's it for apnea of prematurity. Next is talking about SIDS, and that stands for Sudden Infant Death Syndrome and Apparent Life-Threatening Events. So it was amazing how for many years, parents would wake up in the morning and their newborn is dead in their crib. And nobody knew. They said, oh, it just happens. And then they found out that the reason that they're dead is because they suffocated. So when newborns are born, their head is heavy. It's like the heaviest part of their body is their head. And their muscles aren't real strong yet. So if their face gets face down on the mattress, they don't have the strength to lift their head and turn it to get a breath of air. So their head stays buried in the mattress and they literally suffocate themselves. So when that was realized, it's like, okay, don't put your baby face down in the bed. And the thought used to be, well, if they have some reflux from their feeding, instead of them aspirating it into their lungs, it'll come out onto the sheets or whatever. So that was a thought given back in the day. So then the pediatricians then said, no, when you're positioning your baby, always position them on their back when you put them to sleep. Don't put them on, don't lay them on their belly. And then, of course, the incidence of SIDS went way down. It didn't completely eradicate it. So there's other factors, but can you imagine how many babies died because we didn't know that you're not supposed to put them face down in the bed? Isn't it? What is an apparent life-threatening event? An episode of apnea, color change, and hypotonia believed to be life-threatening and which requires intervention. Flaccid, like arms and legs are not moving. So they're not responsive. Yeah, one thing in newborns, when they're awake, alert, their arms and legs are crossed or whatever, or bent instead of flat. When their arms and legs are flat, it's considered that they're not responsive. So it's the leading cause of death in infants between 1 week and 6 months of age. It occurs most often during 2 to 4 months of age. So the reason for that is during the first week, they're not strong enough to move their head at all. So when you put them to sleep, you were putting them to sleep with their head to the side, it stays like that because they didn't have much strength. But then by the 2nd month of age, they're able to move their head around a little bit, but not strong enough to lift it up to get a breath of air. So that's why the death is occurring between 2 and 4 months of age. And that's a test question. Just to let you know. I love when Chris does that. The only time you listen. So when is there the most frequent occurrence of SIDS? It's between 2 and 4 months of age. because they're strong enough to get their head lifted up and bury their face in the sheets, but they're not strong enough to lift their head and move their head to get a breath of air.
Is that what I'm picturing, like newborns, when they put like pillows on both sides of them, like, so that way, like, if they turn their head, they can't like put their head into the pillow or their crib, I don't. Can't remember.
Yeah, I've seen where they put a pillow underneath them to keep them not flat, but turned a little bit. Is that what you're thinking?
No, I think
Or-
I'm picturing like when there's a pillow on like each side of them, so that way like they don't.
She's talking about the bumper for the crib. It's like a little padding around the crib, so they don't like fall to the sides. It's a little.
Oh, I see.
around.
I don't know.
She's talking like directly around, like in NICU the other day, they had it around each baby, they had like like a round pillow that was like literally right around the baby.
It's a bumper.
And that's to make them feel secure, right?
Yeah, it's kind of snuggling and
That's what I
it's like little seats, like they just kind of sit inside of it. They don't really move around.
Yeah.
It's to, all right, so it's possible it's there to keep them from moving
Yeah,
around.
I was just curious.
Or it could just be to make them feel secure. I know they like to be swaddled in a blanket because that makes them feel good. Sorry, you asked?
Yeah.
50% of cases are related to placing the infant in the prone position when putting them to sleep. Another major factor, or another major risk factor, is maternal smoking during pregnancy. Why that causes SIDS, I don't know the connection, but having mom smoking during pregnancy does increase the risk. So there is an apnea alarm on a patient who is 33 weeks gestation and on no supplemental oxygen. When you arrive at the bedside, her heart rate is 90 per minute, saturation is 79%. What should you do first? Observe until the heart rate is less than 60. Letter B, call the nurse and physician to the bedside. Letter C, provide tactile stimulation. Or letter D, begin positive pressure ventilation. Yeah, so you think, are you thinking letter C or letter D, one of the two?
Wake them up, see if the swallows up. And then, if not, begin PPV.
Yes, very good. So do the least invasive first, which would be stimulate them first to see if they start breathing and their O2 sats come up. But if stimulation doesn't work, then yes, then they would need letter D. The patient begins breathing again. This becomes the 5th episode of apnea with bradycardia and hypoxemia in the last 4 hours. The nurse states that the patient is scheduled to be discharged home in the AM. So premature, doing well, and now has apnea. So the infant likely has apnea of prematurity. Number 2, should be discharged on a home cardiorespiratory monitor. 3, may be septic. And 4, should be prescribed caffeine citrate. And 5, should not be discharged home in the AM. So there's some things that are not being told to you in this. Because as far as the correct answer not being what we think it would be, with the apnea occurring all of a sudden, it's possible that there's an infection and that can also cause apnea and bradycardia. So just if the scenario would have read a little bit different, like the baby has been stable for 2 weeks and is getting ready to be discharged home and suddenly develops, apnea, bradycardia, and desaturation. That's going to give us a clue to something's going on. It's not just because they were born prematurely. something's going on. So I don't think the scenario sets us up correctly. If it was just a plain old apnea prematurity, needs to have caffeine, needs to go home on a monitor, then, that's the direction that we would head in. But the fact that they don't tell us that the baby's been doing fine and it is now deteriorating.
We don't even know about premature.
33 weeks.
Oh, you see, that's. the same baby from the-
Yeah.
And it doesn't say how long the apnea period is. Does it, it needs to be longer than 10 seconds for the apnea prematurity?
Greater than 10 seconds?
Yeah.
Yes.
So because it doesn't say that, does that mean that it's not that? Like, would that be a clue or?
An episode of apnea has to be 10 seconds or more.
Oh, so, okay.
So that's a given.
Is there really no difference between like the apnea prematurity and regular, and I guess, is there a difference between apnea and apnea prematurity?
No.
Okay.
No, apnea associated with prematurity would be the same thing as an apnea from another reason.
What would be considered a prolonged episode? Where you would give the caffeine citrate and the
Not that it's a prolonged episode because you're going to intervene. But it's the frequency.
So in this case, since it's happened a few times.
Yeah, so if we assume like the baby is born and they're having periods of apnea. So there are 33 weeks gestation, periods of apnea. They're having apnea of prematurity. What should we do? Yes, you're correct. Give caffeine to stimulate them. Send them home on a monitor so that there's an alarm if they become apneic, and give them caffeine citrate. But this baby has been fine and now develops apnea. So now they're looking at sepsis, maybe another cause for the apnea of prematurity. So 1, 3, and 5. No, only 3 and 5. They're claiming is the correct response. All right, so I don't like that scenario. And last we have omphalocele versus gastroschisis. And sometimes the intestines are born outside of the body instead of inside the body. Sometimes it's just the intestines. Sometimes it's all the abdominal organs. Omphalocele, there's a birth defect of the abdominal wall. The infant's intestines, liver, other organs stick outside of the belly through the abdomen. The organs are covered in a thin, nearly transparent sac. This occurs in 1 out of every 5,000 babies in the United States. If just the intestines are outside of the wall, it's gastroschisis. And again, it's just a hole in the abdominal wall. And this occurs in 1 out of every 2,000 babies. Why does it happen? It's increased with alcohol use or tobacco use during pregnancy. If mom is taking antidepressants, have you ever heard of SSRI, serotonin reuptake inhibitor? That increases the risk. It occurs with teenage pregnancies. It occurs with obesity. And you can see on a prenatal ultrasound how the intestine, you see the intestines outside of the abdomen. So routine blood tests show high level of alpha fetoprotein with gastroschisis. I don't know anything about alpha fetoprotein. So this is high with mom, I guess. And when they see that it's high, it makes them suspect the gastroschisis. But they do ultrasound prenatally all the time. So I don't know why they would need the blood test because they can see. So as far as putting the abdominal contents back into the baby's abdomen, it doesn't fit very well. So it's not like they can just make a large incision, push it in, and then sew them up and everything is fine. It has to be done in stages. So they'll put a plastic bag over the intestines, and they'll slowly push the abdominal contents back into the abdominal cavity. So every day they'll advance a little bit more and slowly push it back in. They call this plastic bag a silo. It's a moist, sterile plastic pouch used to cover the organs outside of the abdomen.
There are issues like kinking or binding
Of the intestines,
the intestines.
like them getting obstructed.
Yeah, they put it back in. Is there any like rhyme or reason or order to how that has to all be? No.
Is there any rhyme or reason or order as to how it's done? Yeah, they just like roll up the bag every day and they just push a little bit more in. Can that cause kinking? I'm not sure.
As it goes back into abdominal cavity. They have cases of intestinal problems.
That I don't know. Like once everything is back in, do the infants have bowel obstruction or problems with their intestines? Yeah, I'm not sure. How does treatment by abdominal wall closure affect ventilation? Well, it increases intra-abdominal pressure. It says the increase in abdominal pressure may interfere with expansion of the diaphragm and venous return, impeding ventilation and oxygenation. So when the abdominal contents are being pushed in, it pushes on the diaphragm. So if you're ventilating with pressure control, you're going to notice that your volumes are getting smaller after they do the procedure for the day. And the reason is by pushing the abdominal contents in, you're pushing up on the diaphragm, and now the diaphragm doesn't have as much movement, and then you end up getting smaller tidal volumes. So on a baby, like a normal tidal volume could be 12 mLs, 15 mLs. It's like a normal tidal volume. And then after they push some of the abdominal contents in, you might notice that your volumes go down to like 6 mL or 9 mL. So it does affect ventilation when they're doing this. As far as venous return impeding ventilation and oxygenation, it's just pressure on the inferior vena cava as you're pushing stuff in. You're impeding blood flow back to the heart. Okay, and then our scenario, after the surgeon advanced several inches of bowel into the abdomen, the ventilator began to alarm low tidal volume, although the peak pressure was being reached. What do you think is the cause of the alarm? Very good, letter D. Necrotizing enterocolitis. So we know that necrotizing means dead. Enterocolitis, so inside the colon or inside the intestines. Itis means inflammation. Blood flow to the intestines in premature babies is not always the best blood flow going to their intestines. And if you don't have good blood flow going to tissue, it ends up dying. The intestines, when they're premature, they're not ready for food to be in the intestines and for nutrients to be taken from the intestines into the bloodstream. So there isn't much blood flow. And sometimes that lack of blood flow can cause that necrotic tissue to occur. Sometimes the food put into the stomach, the intestines, it's not being absorbed and it just sits in there. And it can cause problems with inflammation of the intestines around it. So once the part of the intestine is necrotic and dies, it sets out for a nasty sepsis in the newborn. All right, so it says NEC is a serious complication of primarily premature newborns. So you're not going to see this in full gestation newborns, you're going to see it in the preemies. It causes hypoxic, ischemic, and inflammatory damage of the GI tract. And then, of course, if you don't have oxygen delivered to the intestines, the tissue dies. The intestines may rupture and leak intestinal contents into the peritoneal space. So having a dead piece of intestine, and especially when it ruptures, and now the contaminants inside the intestine leak into the sterile space in the abdominal cavity and set up an infection. So what is the cause? The prematurity is one of the causes, or not the causes, but the reason it occurs. Food introduction causes enteral tissue inflammation, which leads to tissue necrosis. So just having food in immature intestines causes it. And hypoxic ischemic insult to the GI tract due to poor perfusion of the intestines by the mesenteric artery. So the mesenteric artery is the artery that gives blood flow to the intestines. And if you don't have good blood flow to the intestines die. So how does this involve the lungs? The infant will present with sepsis and poor oxygenation. So they're going to have edema in their lungs, even though the sepsis is occurring in the intestines. Decreased lung volume due to abdominal swelling, preventing good diaphragmatic movement. And I don't know if this picture can show very well, but you see like a mottled look over the abdomen. So physical signs include mottling. Our mottling look to the skin over the abdomen. And that's another telltale sign that they're becoming septic. So on this abdominal X-ray, you can see, well, the loops of intestine and having air inside the intestines, that's considered normal. But what's not normal is when you see air outside of the intestines. So do you see this black area on the outside of the intestinal wall? So that's how they know that there's been a rupture of the intestines, and air and abdominal contents are leaking into the abdominal cavity. So of course, they stop the feedings, they give them antibiotics. If the sepsis leads to coagulopathy problems, then they correct that. Blood transfusions, I don't know how blood transfusions help. And then supportive cardiorespiratory care. 20 to 40% of infants that present with this need to have surgical intervention where they remove the necrotic area. So because of the pulmonary edema that occurs with sepsis, they're going to need a lot of times intubation, mechanical ventilation. They're going to have low lung compliance because of the pulmonary edema. Sometimes they require high frequency ventilation to ventilate them. So we have a 2-day-old premature baby was rushed to the ER via ambulance after the mother, who was 17 years old, gave birth preterm and noticed that the baby was not feeding. Initial assessment of the baby was done by the ER doctor and was found to have distended, tender abdominals, intolerance to feedings as reported by the mother, rectal bleeding, erythema of the abdominal wall. Oh, I called it modeling. So there's a more medical term for it. Nasal flaring and unstable body temperature. A stat abdominal x-ray was ordered and results show multiple dilated bowels with pneumatosis intestinalis. A lot of air in the intestines. Lab reports came back showing evidence of abnormally low platelets, abnormally low neutrophil count, and a severe metabolic acidosis. IV fluids and ampicillin were immediately started, and the patient was intubated and transported to PICU. The clinical presentation is indicative of which of the following. What did you say, Marlon? Yes, very good. Letter E, both A and D. So necrotizing enterocolitis and septic shock has resulted. All right, we'll take a break. All right, next we'll talk about retinopathy of prematurity, ROP. And believe it or not, what we do as respiratory therapists can affect the eyes. What?
Too much oxygen.
Yep, very good. Too much oxygen. So prematurity is a key word here because this doesn't happen if we give too much oxygen to a full gestation newborn, but it can happen if we give too much oxygen to a premature baby. So in the retina of the eye, the blood vessels are developing still in a premature baby. And if the oxygen is given, it causes these blood vessels to grow like crazy. And there's so many blood vessels that it actually causes the retina to detach from the back of the eye, and it causes them to be blind. So let's see what our notes say, and then I'll write it in the chat. So causes is over oxygenation in premature neonates. And then just to clarify, it's not that you're giving 60% as your FiO2. It's the fact that the PaO2 is high. So ROP occurs when the PaO2 in the blood is elevated. It doesn't occur because we're delivering high amounts of oxygen to the lungs. So if the baby needs 60%, or I'm supposed to say 0.6, aren't I? 0.6 FiO2 to get a PaO2 of 50, that's not going to damage the eyes. Does that make sense?
I'm sorry, you probably already done. What if the PaO2 is normal for a preacher?
55 to 70. So there are other causes that lead to ROP. Here it mentions heart disease, high CO2, infection, respiratory distress, transfusions, diabetes. So what you're asked about on your exam is ROP and the causes of high oxygenation leading to ROP. It says the supplemental oxygen alters the regulation of vascular endothelial growth factor. And that's what leads to these blood vessels growing out of control. That's not a test question. That's just in case you were curious as to the connection between the oxygen and the crazy growing of blood vessels. It's because the oxygen interferes with the vascular endothelial growth factor. So there's different stages of this neovascularization. In the picture, it shows stage 1, you've got some increase in blood vessels. Stage 2, it's moderately abnormal blood vessel growth. Stage 3 is severe abnormal blood vessel growth. Stage 4, you actually see the retina detaching from the back of the eye. And in stage 5, you have a completely detached retina, an end stage of the disease. So not reversible, the damage has occurred.
So is
Taylor?
it not reversible once stage 5, or like say if you have stage 1, that's not reversible either, and then it just gets worse and worse?
It is reversible.
So it's
Up
all reversible
to-
until,
Yeah, a completely detached retina, I don't know if they can do anything about that.
how do you reverse?
They use a laser in the back of the eye and cauterize the blood vessels, and that stops them from growing. Delivering vitamin E to the eye also helps prevent this overgrowth of blood vessels.
So once they notice it happening, are they able to start that, or?
Yeah, it's part of a routine examination for all preemies, where an ophthalmologist comes in, looks at the back of the eye, and then reports if there's anything abnormal occurring. They'll treat it right away.
So it's actually probably very uncommon to get to stage 5 due to all of the precautions.
Nowadays, yes. 20 years ago, a lot of kids were blind because nothing was done to stop this from occurring. So to prevent it from occurring, avoid premature birth and avoid the use of excessive oxygen therapy. Keep the SATs between 85 and 92%. So we're gonna keep with this O2 sat. So when you're taking your exam or you're asked, what is a normal O2 sat for premature babies? We're gonna continue to use 85 to 92%. The policies they change between Joe DiMaggio, Broward Health, and, within the institution, it changes. Currently, they're using 85 to 95%. I think Joe DiMaggio is using 88 to 95. Where are you? Joe
I
DiMaggio?
saw 93 on most of the things it was saying to keep at, like,
Keep at 93%.
yeah. Like no higher than 93.
Oh, okay. So
The
no
high
range
one
was
like
given.
85 to like 93.
85 to 93. Oh, okay. So the alarm is set at 84% to go off, I guess.
Yeah,
Okay,
versus, I mean, I think some of the babies were different, but a lot of them were different.
okay.
The highest that I saw was 90. Yeah. And this was at Broward,
Okay.
something like.
And if it goes to 95%, you hear an alarm?
No one got to 90,
Okay.
so.
I
I'll
think
look
there
out.
was an alarm sounding for us, because we had one baby who kept fluxing. And we had to keep turning his oxygen up and then turning it down, and then he started satting really good. And I don't think it necessarily was like alarming, but you could see it blinking, so we turned his oxygen back down because we wanted to titrate him off of it if he's satting good. So,
And the changes that you make in the FiO2, how many percent do you change it?
he was telling me just do like 5% at a time.
5, wow.
But he would, it varied, because sometimes the baby would just start desatting a little and you just flick it up a little bit. So, like 1 or 2, like 2
Yeah.
or 3%.
Yeah, 2% is like a big change, so. Which is different from adults. When do we ever change an FiO2 2% on an adult? So it's the high PaO2, not the FiO2, that causes the damage. Minimize abrupt changes in FiO2 when SpO2 is outside normal range. Before increasing FiO2, ensure that the patient is hypoxemic. So it used to be so typical to just turn their desatting, put them on 100%, O2 sat comes up, and then slowly try to get them back down. Nowadays, they're keeping a better tab on what the O2 sat is, and you don't see them turning it up to 100% anymore. At least you shouldn't be seeing that. Use oxygen and air blender. And remember, when we're using a blender, we can have a lot of flow, but we can adjust the FiO2 of that flow. So we can start off with 21%, increase it to 22%, but have a good enough flow coming out. ROP results in the detachment of the retina. ROP affects premature neonates and full-term neonates. Is that true or is that false? That's false. It's preemies only. So full-term neonates already have their blood vessels developed. So excess oxygen doesn't do anything to the eyes. Treatment to reverse the effects of retinopathy of prematurity consists of A, laser ablation of the affected vascular area. B, administration of vitamin E, limiting light exposure. Careful use of supplemental oxygen, or none of the above, or all of the above. All of the above. Did we miss something?
Did we go over what vitamin E does?
It's like an antioxidant. It protects the eyes from damage. So
In general?
it's something general. Yeah.
Okay.
we missing something or does it go right into this? Yeah, it's missing air leak syndromes.
It's on the next.
It's on the next
Oh, is it?
Yeah, it's pretty out of order. Two slides.
Oh, so air leak syndromes occur when air escapes from the lung into extra alveolar spaces where it is not normally present. So when it says air escapes from the lung, usually it's the lung parenchyma, usually it's the alveoli, like a ruptured alveolar capillary membrane. So that's what it means by the lung.
So it's like subacute here.
Yes, that's a good example. I don't know how to put that into a sentence, so I'll just combine them together. How's this? I just put air escapes from ruptured alveoli in the alveolar capillary membrane. So it's the alveolar capillary membrane is the alveolus. So it's kind of a weird sentence, but that's where the tear occurs. And then air in the alveolus now gets into the interstitial space, and then it starts traveling through the interstitial space, and then eventually can be throughout the lungs and into the pleural space. Overdistension of the airways can result from uneven alveolar ventilation, air trapping, or high pressures that distend the alveoli in infants on ventilatory support. This leads to a tear in the alveoli or other lung tissue. Most commonly, we get a pneumothorax. How do you treat it? Use low mean airway pressures, reduce your peak pressure, reduce your PEEP, reduce your inspiratory time. Put a chest tube in, placed in the anterior pleural space, connected to an underwater seal with continuous suction. Oxygen therapy. Oxygen can speed up the reabsorption of air. Small air leaks resolve on their own. So if you have like a 2% or 3% pneumothorax, will they put in a chest tube? No. So they'll wait for that air to just get absorbed on its own and nothing will be done. But then if it keeps increasing in size, then they'll put in a chest tube. Is this an obvious chest X-ray? What's wrong with it? Tijin, do you know? On what side? On the left side? Your left or the baby's left? The baby's left? So right here? Yeah. All right, so this looks like a pneumothorax to you?
Yes.
But pneumo means air, so shouldn't it be really black if that's a pneumothorax?
But like, when I'm looking at it, I see the lungs like collapse to one side. And there's a tracheal tube.
Is it shifting towards the left or shifting towards the right?
The baby's right.
The shift is towards the right?
Like you see the outline of the moon?
Here?
That's perhaps,
So look on this side, where there's black, there's air. So there's a lot of air in this pleural space. We don't see any vascular markings, so we know that this is outside the lung. And it's pushing the lung and collapsing the lung. So this is a pneumothorax on the right side.
I got it. I got the black and white.
Okay. Yeah, pneumothorax is going to be black. You'll see black and then you'll see no vascular markings. That's how you can tell.
Like the first picture you put up, you had it in the wrong place. I think it's the one zero, but what is this one? We have it in the.
Go back. You're asking about this picture?
Yeah.
Air around the heart is called pneumopericardium. So how is a chest X-ray diagnosed? How is a pneumothorax diagnosed? And the answer is chest X-ray. CT scan, yeah, it's true that you can see air in the pleural space on CT scan, but that's not a very quick way of diagnosing. And then transillumination is holding a flashlight up to the chest. And when it's hyperlucent, that means that the light is shining really bright versus not having a pneumothorax that absorbs the light. As far as symptoms go, it says many affected neonates are asymptomatic. They'll have some diminished breath sounds. Hyper-resonant percussion. What is that? Hyper-resonant percussion. It's not dull. I like that. It sounds like an empty barrel.
I can't remember which one.
Like an echo, right?
Yes, very good.
Like if you stomp on one.
Yes. Very good. So when you put your fingers on the chest and then you tap your fingers, you'll hear different sounds depending on what's in the thorax. A lot of air sounds hyper resonant, loud, I guess. And normally it sounds like a thud, or the thud is for pleural effusion.
It's in our patient assessment from last semester from our disease class.
Good place for it. Okay. Why does hypotension develop with a pneumothorax?
This is the compression of the heart.
Not going to be pumped out as much
Yeah.
because the heart is being squeezed. And what about venous? Yeah, venous return to the heart also is compromised from that, all that extra pressure in the thorax. So treatment, again, this is not in order. So we know that treatment of a pneumothorax is putting a chest tube in. So we'll take away the word treatment. Now we're talking about pulmonary interstitial emphysema. And it looks, I'm going to give you the right description of the X-ray because it's important. So with pulmonary interstitial emphysema, air leaks into the interstitial spaces of the lungs. So let me type that first. Chest X-ray shows linear or tiny cystic translucencies. These extend from the hilum to the periphery of the lungs. So tiny cystic translucencies. When you look at the X-ray, can you see something's up? It doesn't look right. So if you look carefully, you see lots of little white circles. So those are considered cystic translucencies.
Little white circles or black circles?
The black circles. Yeah, we see a combination, don't we? Don't we see white circles and black circles? And together they're making up this hazy looking appearance. I agree. And then what else does it say? PIE generally affects both lungs symmetrically. So PIE generally affects both lungs symmetrically. So it's not like the two cavities are connected. So it must mean that they're getting damaged equally. So to have air leaking into the interstitial spaces on the right lung, how does that get over to the left side and affect all of the interstitial spaces in the left lung? It doesn't. So it's got to be damage is occurring to both lungs, causing the PIE. So the air can migrate around the heart. And I don't know if when you look at the X-ray, it's obvious, but if I point out this black space surrounding the border of the heart, not as obvious on this side, but that tells you that there's air in the mediastinum. So how would I word that? Air around the heart, I guess is good enough. Oh, you're right. Yeah,
See, I understand.
yes.
Could it be both or?
So air in the mediastinum also surrounds the heart. So air in the mediastinum can also show up as pneumopericardium. I'll type it.
Mediastinum is the space between the lungs and the heart, right? Pericardium would be like air actually inside the pericardium.
In the pericardial sac.
Yeah.
Yeah. Yeah, so trauma can cause, I don't know, I guess trauma can cause rupture of the pericardial sac and then air will migrate into the sac. So air in the mediastinum also affects the heart. Air around the heart shows up as pneumopericardium. And this is specifically for pneumopericardium. A pericardiocentesis should be performed on symptomatic infants. Minimize ventilator pressures to avoid making it worse.
See, that's the same picture you had for the other one, so.
Yeah. Okay, so. Pneumopericardium. What can be caused by air leaks in infants? Subcutaneous emphysema, pneumothorax, pneumonia, popsicles. What do you think?
Did you make this question up yourself?
Pardon?
Did you make this question up yourself?
No.
Yeah, I figured.
Is popsicles an actual thing?
Yeah, it comes on a stick. You put it in the freezer, keep it cold.
Yeah, because it's not, well, like popsicle was spelled with an S.
Oh, yeah.
Oh, that for a C is, so I didn't know if like with a C was an actual medical thing.
Good point. Very good point. So yes, letter C, subcutaneous emphysema and pneumothorax. How would you treat a symptomatic infant on a ventilator with a tension pneumothorax? Yes. So these questions came from Scott when Scott was teaching air leak syndromes. Okay, and that was it for air leaks. And now we're on to choanal atresia. And when you look inside your nasal passage, you should see darkness, meaning an open passage. But when you just see tissue covering the opening, now you've got an obstructed nasal passage. When babies are born like that, it's called choanal atresia, where the nasal septum doesn't develop correctly. Here it's showing unilateral choanal atresia, and here it's bilateral choanal atresia. It's diagnosed when severe respiratory distress appears to lessen with crying. Insertion of an oral airway provides temporary relief of the obstruction. So why not a nasal airway? Very good. Oh, that was the end. I'm going to leave the recording running while we review all of the different neonatal conditions.
Would have been a lot better if you had all this stuff filled in first.
when you create Quizlets yourself, you learn a lot better than having somebody else create the Quizlets and you're just looking at them.
Yeah, I don't remember exactly.
That's very nice of saying nothing.
Spoon fed.
You just give me a paper, I'm probably gonna read it 50%, whereas if I sit and make a Quizlet, I may remember 75%.
Yeah, it helps
Yeah.
when you're constantly re-going over the information and like typing it in to make the Quizlet yourself.
Yes, exactly.
Presentation we're gonna do we get to pick, or are you gonna just tell us?
You don't get to pick. I put your name in a hat, and when I pull your name out, you present.
So we're not presenting like a PowerPoint.
No,
So whatever notes you have or whatever you use, you pull out the hat, that's what we talk about.
yes. All right, so we'll start off with RDS. So you can put information, you have the sheets in front of you. You can squeeze information in this space, specific info, what the chest X-ray shows, and then we have to determine whether it's present in full-term infants, premature infants, or both. So starting off with RDS. It's caused by surfactant deficiency. I'm going to try just talking and letting you guys write. What do you think? So it's caused by surfactant deficiency. And then I have on my paper less than 28 weeks. Under specific information, I have treat with CPAP and surfactant. Treat with CPAP and surfactant. The most commonly used surfactant is Curasurf. It's considered porcine or from pig lungs. The dosage.
2.5 initial.
For-
2.5, second and third dose, control up to 5.
What are the units?
Tell you almost everything you need to know about your surf.
Okay, what are the units?
Volume is 2.5 milliliters per kilogram.
Milliliters per kilogram, very good.
Or 200 milligrams per kilogram.
200 milligrams of what?
If you're doing going by volume, it's 2.5 milliliters per kilogram, or the dose would be 200 milligrams per kilogram.
Oh. So we don't need milligrams. Pharmacy mixes it, and when they give it to you, it's like an ml bottle, and you just have to know how many mLs to take out the bottle.
1.5 milliliter bottle or 3 milliliter bottle. One single use.
I should give you extra credit more often. Chest X-ray. Very good. You're gonna see air bronchograms. And the X-ray is going to have a ground glass appearance. So air bronchograms and ground glass appearance. Yes. Does it affect full term, premature, or both? It's mostly premature babies.
But it can affect both.
I would like for you to remember that it's premature.
You said less than 20 weeks.
Yeah. There are some cases where surfactant is not present in a full-term newborn. But to simplify matters, I want us to remember that it's mostly caused by lack of surfactant in preemies. All right, next is BPD for bronchopulmonary dysplasia. The other name to it is neonatal chronic lung disease. So neonatal chronic lung disease. Under specific info, I have that it's due to underdeveloped lungs that required mechanical ventilation. Underdeveloped, would it be better to say premature? Premature lungs that required mechanical ventilation. And then if you can squeeze this in for the diagnosis, and you can abbreviate diagnosis as DX. And the diagnosis is O2 therapy after 36 weeks of gestation. O2 therapy required after 36 weeks gestation. Also right, ABGs are like COPD. ABGs are like COPD.
So they're compensated.
Yes, so CO2s are high. It's a compensated respiratory acidosis. For the chest X-ray, oh, did you guys get all of that, by the way? Brent, give me a shout out if you need me to repeat anything.
No, okay.
For the chest X-ray, it's hazy, cystic emphysema. So it's hazy, there's cystic emphysema, and you see hyperinflation. So hazy, cystic emphysema, and you see hyperinflation. Is it full-term premature? It's pretty much premature babies.
And then I forgot, can they grow out of this or no? Like, can they, because emphysema in general, you can't really, it's not reversible, is it? So.
So the lungs are continue to develop after birth. So yes,
So they can.
yeah. Good to go? All right, next is PDA, patent ductus arteriosus.
Professor, sorry.
Uh-huh.
Full time or?
It's preemies, mostly preemies. The reason I'm putting mostly in front of the word, number one, I want you to remember that it's when I'm talking about RDS and BPD, it's the premature babies that suffer because their lungs are so premature. But when you're reading in the textbook, you're going to find incidences where you see BPD in a full-term baby, or you might see RDS in a full-term baby. But I just want to give you like your general information on it. I don't want to go off on a tangent. Well, what about this baby? This baby was born at 38 weeks and look, it has BPD. But you said It was only in premature babies.
You're teaching us textbook, real life is different, right?
Yes. All right, so for patent ductus arteriosus, the ductus doesn't close after birth. The ductus doesn't close after birth. This happens in 60% of preemies less than 28 weeks. Happens in 60% of preemies less than 28 weeks.
50%.
60. And then for specific info, blood flows from the aorta to the pulmonary circulation. Blood flows from the aorta to the pulmonary circulation. It leads to increased pulmonary blood flow.
So, I'm sorry, blood flows to the aorta.
No,
Aorta, pulmonary.
yeah, there's higher pressure in the aorta. So that open ductus will allow blood to flow from the aorta into the low pressure in the pulmonary artery. So aorta to pulmonary artery. For chest X-ray, I don't have anything. I just have treatment listed. Treatment is ibuprofen.
They use Tylenol for it too. When I was at the hospital, we were
That closes it?
They were treating it with Tylenol,
Tylenol and ibuprofen.
both.
Not at the same time, but they would use one or the other, they were telling me, and then the phytomethicin, they like don't really use that anymore because of the GI problems it was associated with.
Oh. Okay. Should I stop teaching it? Will it show up on the national exam?
Like, no idea, I just wanted to cheat.
Yeah, I know that it has like complications. So it's definitely not the drug of choice. But I never know when to stop teaching something.
I just didn't know if you knew that they used Tylenol now for it too.
No, I didn't. So ibuprofen or Tylenol, indomethacin. And if the ductus is still open, then PDA ligation. And even though they call it ligation, remember it's mostly just the banding or the coil that they put around the ductus. They don't actually cut it. PDA ligation, yes.
I saw it too.
What was that other
It's pretty
medication you said? after ibuprofen?
Endomethacin, ENDO methacin. And the drugs work by decreasing prostaglandin levels. Is it full term, preemies, or both? Yeah, mostly preemies.
Do you even be able to see this on a chest X-ray?
Ultrasound, yes. Chest X-ray, I don't think so.
You can see the coil.
You can see the coil.
And you can saw the X-ray of what a baby that had a PDA closed the day before, and you can see the.
Oh, really?
There's the-
I'd like a picture.
oh, let's see, if you want.
Okay.
And this is-
Next is PPHN for persistent pulmonary hypertension of the newborn. So in utero, we expect the pulmonary vessels to have high pressure because they're constricted. But once the baby's born, those pulmonary vessels should dilate and now not be hypertensive. So that's where the word persistent comes from. The pulmonary hypertension continues even after they're born. So under the disease, I wrote pulmonary vessels constrict. And stay constricted. And for the cause, I just put hypoxemia. And again, the textbook lists all these different causes of all these different causes of the PPHN. But when you look at them, they all lead to hypoxemia, which is why the pulmonary vessels constrict. So that's why I kind of just leave the causes as hypoxemia. So it's like hypoxemia around the time of birth. This will cause a right to left ductal shunt. So write that down, and then I'm going to ask you if you remember what that means. Right to left ductal shunt. From where to where? Right to left.
Lungs to where you want it.
Or the right atrium to the left atrium instead of going through the right ventricle.
So we're comparing the aorta and the pulmonary artery.
Oh, I'm jealous.
Don't listen to me. So right, yes, so right to left would be pulmonary artery to the aorta. So right to left shunt is the pulmonary artery to the aorta,
So bypassing the whole left side.
bypassing the lungs, yes, and the left side of the heart. Tidjin, does that make sense?
Yes.
You sure?
Yes.
Okay. So when you have pulmonary hypertension, the pressure becomes higher in the pulmonary vessels than the aorta. And now instead of the blood flowing to the lungs, the easier route to take is to go through the ductus into the aorta. That becomes the pathway of least resistance. And that's why you get so much shunted blood with PPHN. And then under chest x-ray, I don't have information, but I used the space to mention preductal. PaO2 is the right radial artery. Preductal PaO2 is the right radial artery. Preductal PaO2 use the right radial artery.
Use the right radial artery. The right radial arteries, use that.
Man, you get scolded with you. My R2 went over like all this is accounted on the writing. And we're just. You want?
Did you say I just had it in a lecture? I don't have it committed to memory yet.
No, I kind of remember that one, but you went over a lot of stuff. Good.
And then postductal is the umbilical artery or either foot.
These boxes are way too small for all this.
I know you write so big. Do you want a second piece of paper?
Yeah, are we gonna allowed to have our own notes when we present?
Yes,
Okay. Don't worry about it.
You said postductal as well.
umbilical artery in the legs. No. So greater than 20 torr difference. I don't know why they don't give us an O2 saturation difference. I mean, we've got the pulse ox on the right hand, pulse ox on one of the feet. We're looking at O2 sats, and then when you go to the textbook, it doesn't tell you the difference in O2 sat. It only tells you the difference in PaO2. But the difference is 20 torr indicates shunting is occurring. So a 20 torr difference in PaO2, shunting is occurring. And then for diagnosis, actually, that was part of the diagnosis. All right, so the two things to the diagnosis, the greater than 20 torr difference in PaO2. The other thing for diagnosis is an echocardiogram showing right to left shunt. So an echocardiogram, I guess it tags the blood flow and it can see where the blood is flowing. So echo, would it be cardiogram if it's looking at pulmonary blood flow? All right, so just echogram shows right to left shunt.
It happens in full-term babies, right?
Yes. It happens in full-term babies. Yes.
Like when you say nitric oxide is used to treat it.
Yes.
Before we move on to a different disease, I have a question.
What's your question?
So I was confused like between the hyperoxia test and the hyperoxia hyperventilation test. Like what confirms a shunt? So 100% O2 is given for 10 to 15 minutes to dilate the pulmonary vessels. If the PaO2 that improves, a shunt is confirmed. Is that correct? Okay, and then for the hyperoxia hyperventilation, the neonate hyperventilates, 100% O2 is given, and the alkalosis causes the pulmonary vessels to dilate. Post-ductal PaO2 improves, confirming a shunt. It's also true. Okay, good. I just wanted to
Yes,
make
you
sure.
have it correct.
Okay, thank you.
Next is meconium aspiration. It's aspiration of meconium. Due to a hypoxic event. So I wonder if instead of a hypoxic event, we should say fetal stress in utero. Of course, the fetus is in utero if it's a fetus. How about due to fetal distress? Okay, and then for specific info, I have greenish fluid present on the skin. May have difficulty breathing. Greenish fluid present on the skin. And may present with difficulty breathing. If so, suction and then intubate. Chest X-ray will show hyperlucent in areas. Hyperlucent in areas. Depressed diaphragm. Is there a better word than depressed diaphragm? Flattened diaphragm. Flattened diaphragm. Possible pneumothorax. And it affects full-term newborns. Or full-term babies, full-term. Just full-term. You guys need a break? We went past break time. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 more to go.
For a minute.
All right, 10-minute break. Oh. Okay, we'll keep going. So we finished with meconium aspiration. And now we'll talk about neonatal pneumonia. So common organisms are group B strep. E. coli. And Pseudomonas.
What was the first one? I'm sorry.
Group B strep.
Oh, group B.
Can you say one time?
Group B strep.
E. coli.
Yes. Yes. 3 ways to get pneumonia. You too can have. Number 1, across the placenta. Like viruses can cross the placenta. Number 2, ruptured amniotic sac. Okay. So number 1, across the placenta. Number 2, ruptured amniotic sac. Ruptured amniotic sac. And then write down PROM, because you'll see that a lot in the medical record. PROM, premature rupture of membranes.
Is that for number 3 or just along with number 2?
No, it's not. It's along number 2.
You said premature rupture of membrane.
Premature rupture of membranes, PROM. And remember the connection, when the membranes rupture, there's no longer a sterile environment for the fetus, and microorganisms can get into them and cause pneumonia. And then number 3 is late onset after birth. Poor hand washing can lead to contamination.
What hand washing is it?
Poor hand washing. For the chest, is that okay now? Yeah, chest X-ray. You see infiltrates. Either one side or bilaterally. So infiltrates, one or both sides. And it affects both premature and full term. Next is CDH for congenital diaphragmatic hernia. The abdominal organs are in the thoracic cavity. So CDH, the abdominal organs are in the thoracic cavity. Usually occurs on the left side. And then if you have room, the pleuroperitoneal canal does not close. Pleuroperitoneal canal does not close. I guess that's referring to the area on the diaphragm, the pleuroperitoneal canal. And then for specific info, I have it compresses the heart and lungs. Compresses the heart and lungs don't develop. So compresses the heart and lungs, and the lungs don't develop. And remember, it affects not only the left side, but it can also affect the lung development on the right side. When lungs don't develop, what is the name for that? Do you remember this from your medical terminology? Hypoplasia, pulmonary hypoplasia. And then for chest x-ray, I don't have chest well, I guess a chest x-ray would show it. But you see abdominal contents in the chest. So abdominal contents in chest. Also, scaphoid abdomen. Scaphoid is SCAPHOID, scaphoid abdomen. Scaphoid, SCAPHOID, scaphoid abdomen. Like there's the abdominal contents aren't there, so it's kind of caved in, and that's called scaphoid. Do not bag unless NG tube inserted. Do not bag. Best to intubate right away. Best to intubate right away. So treatment would be, oh, I have all of the respiratory treatment. I don't have the treatment for getting the abdominal contents back into the abdomen. So I guess treatment would be surgery eventually. And then also ECMO and high frequency ventilation for respiratory support. So ECMO or high frequency ventilation. So for treatment, you wrote surgery eventually. And respiratory wise, ECMO and high frequency ventilation.
Is this for full term?
Both,
I mean, the
because it
moment-
happens, I think the 8th week of gestation.
the moment can be both also, or just the.
Mhm. Yeah.
Sorry.
Okay, next is TTNB. Am I going in the right one? Yeah. TTNB for transient tachypnea of the newborn. There is delayed clearing of fetal lung fluid. Delayed clearing of fetal lung fluid. Delayed clearing of fetal lung fluid. And then for specific info, I wrote most common in C-section babies. So most common in C-section babies. Respiratory rate 60 to 150 per minute. Respiratory rate 60 up to 150 per minute. For chest X-ray, I have prominent perihilar streaking due to engorged lymphatics. Chest X-ray, prominent perihilar streaking due to engorged lymphatics. And it affects both preemies and full term. Next is apnea of prematurity, which is cessation of breathing for 10 seconds or more. CESSATION, cessation or stopping. Cessation of breathing, 10 or more seconds. Also bradycardia and desaturation occurs. For specific info, is your hand cramping? I have CNS is not developed, the central nervous system not developed. Treatment, stimulation, tactile stimulation. Do you know what that means? Tactile, TACTILE. No, you don't shake the baby. Tactile, TACTILE, tactile stimulation. So if you, wiggle their leg, rub their back, tickle them under the arm. If that's not working, then bag valve mask. Or if that's not working, ventilate with bag valve mask. Treat with caffeine. Doxapram and CPAP. And I have nothing for chest X-ray, and it affects preemies. The more premature they are, the more it's going to happen. For SIDS, sudden infant death syndrome, babies die during sleep. Occurs in infants 1 to 6 months of age, but not much in the first month. So 1 to 6 months of age, most common 2 to 4 months. And 50% of infants, they were in a face down position. There's increased risk with maternal smoking and antidepressant use. So increased risk with maternal smoking. And antidepressant use. And it can affect both premature and full term. Next is euphalocele. Intestines and organs. And covered sac are outside the body. Intestines, organs, and the covered sac are outside the body. Oh, I missed liver, didn't I? Good enough, other organs. And then I just have treatment is slowly over time. Contents are pushed back into the abdomen. So slowly over time. Contents are pushed back into the abdomen. This interferes with ventilation. This interferes with ventilation. Is that good enough, or do you want to say because of pressure on the diaphragm? Is it good enough to just say it interferes with ventilation, or if you want to mention the diaphragm, it pushes up on the diaphragm? Let's see, diagnosed by prenatal ultrasound. Diagnosed by prenatal ultrasound. It occurs in full term and premature babies. Gastroschisis, another congenital birth defect. Intestines are outside of the body. Intestines are not covered by a sac. And then for treatment, use silo, SILO. That's the plastic bag that they put over the abdominal contents, and then they just slowly put pressure on the top of the bag, and that pushes the intestines in. So I just have use silo, SILO. There's an increased incidence in cigarette smokers, alcohol use, and young mothers. Increased incidence in cigarette smokers, alcohol use, and young mothers.
What's happening for cigarette smokers?
Increased incidence with cigarette smokers, alcohol use, and young mothers. Next is NEC, necrotizing enterocolitis.
Sorry, was that one for preemies or both?
Both. Okay, NEC is ischemic. I have ischemic bowel or ischemic intestines due to low perfusion. So ischemic intestines due to low perfusion or feeding to premature intestines or feeding to premature intestines. Causes sepsis. Intestines causes sepsis from ruptured intestines. But it seems like you don't really have to have the, yes, it's true, you're going to get sepsis when the intestines rupture. But just to have an infection in the intestines, it seems like they don't have to rupture to get sepsis, but what did you put in your notes?
On the sepsis from ruptured intestines.
Okay, we're gonna leave it like that. And mostly premature babies. And then for abdominal x-ray, I have free air in abdomen. Do you know what that means by free air?
So it looks so cute.
Ascites is fluid. But when there's air outside of the intestines, like surrounding the intestinal wall,
So cute, or some same as so cute.
yeah, it's kind of like subcutaneous intestinal air. But we can't really use the word subcutaneous because it's not in the tissue layers, it's in the abdominal cavity. So air in the abdominal cavity from the ruptured intestine. Two more to go. So next is ROP, retinopathy of prematurity. Blood vessels in the retina, blood vessels in the retina proliferate. Do you like that word? Grow like crazy, I guess, proliferate, grow like crazy. Blood vessels in the retina proliferate or grow like crazy due to high PaO2s, not high FiO2s. There's different stages. And the worst is when the retina detaches. So there's different stages. I think it was 1 through 5.
Yeah.
And the worst is when the retina detaches from the back of the eye. I have keep O2 sats 85 to 92%. And PaO2 55 to 70. Keep SATs 85 to 92%. Got that? Keep PaO2 55 to 70. And this affects premature babies only. Treatment is laser ablation of the blood vessels. Laser ablation of the blood vessels. For air leak syndrome, are you guys ready to move on? And the last one, air leak syndromes, is over distension of alveoli. Causes a tear in the epithelium. Over distension of alveoli causes a tear in the epithelium. So then air migrates into ... number 1. So air migrates into pleural space, causes a pneumothorax, need a chest tube. Pneumomediastinum. Pneumopericardium. And I don't have any treatment listed for that. Number 3. PIE. For pulmonary interstitial emphysema. This is diffuse air in the interstitial space. Diffuse, meaning throughout, diffuse air in the interstitial space. Need to reduce peak pressures on the ventilator. Need to reduce peak pressure on the ventilator. Wow, we did it.
And that's for
That's
preemies
both?
or just,
It can happen to both.
And then there's one more, choanal treatment.
Oh. Oh, I didn't have it on my notes.
You go for that, you know.
oh, it's the last slide.
The air was a clean.
It's in some nasal passages.
Upper airway obstruction. Can be unilateral or bilateral. Crying relieves the obstruction. Crying relieves the obstruction.
I thought they cry because it's obstructed and once you. It's breathing.
Yeah, but
How
how
do
much
we
the
know
opposite?
be able to breathe? No, I've heard something different for that.
Diagnosed when severe respiratory distress appears to lessen with.
Okay.
So yeah, they're struggling to breathe, and the struggle makes them cry. And as soon as they cry, their mouth opens up enough for air to go in. And then they start exchanging air, O2 sats come up, and they get comfortable, and then they stop crying, and then it starts all over again. Airways obstructed, They start crying, it opens up their airway. Because remember, the tongue is really large. It's hard for them to breathe air through their mouth. So when their nose gets stuffy from a cold, or in this case, choanal atresia, where the membranes are grown over the nasal passage, there's no way to get air through the nose. So the only way to get air in is if they open up their mouth. And they only open up their mouth when they cry.
It's the oral air.
Yes. I should have explained that. All right, so when you go through and get ready for your presentation next week, if you want to add some extra notes, feel free. I gave you like the basics so that you're able to describe the condition.
Final, Atriza and preemies or full term?
Either one.
Oh,
Yeah. Yeah, it's a birth defect, so if they're born prematurely, they'll have it, and if they're born full term, they'll have it. Okay, I will stop the recording.